Hello.
Yes,
Yes,
we
we can see it.
Thank you. Sorry for the delay. Um, had to finish up a few things here and there. Okay. So I'll be taking you through neurological disorders, and part of them is we have headaches and migraines, seizures, Parkinson's disease, Alzheimer's, etc. Okay, so we'll begin with headaches and migraines. Okay. So usually, I think all of us have experienced headaches at some point, and most of the times, headaches can just be treated with normal pain meds, the over-the-counter medications, and some lifestyle changes. Sometimes they usually say just drink some water or take some fluids. Yeah, so usually we have two classes of headaches. We have the primary and the secondary headaches. So primary headaches are those that don't have any underlying conditions, but secondary headaches are those which usually have a separate cause or illness. So they're basically due to something else. So primary headaches can be further classified into the tension type headaches. So these ones are usually the most prevalent type in the general population and typically present with bilateral non-thrombic headache without other associated features. So usually they are mild to moderate in intensity, and they feel like, yeah, the patient will usually feel like they have a rubber band stretched around their head. So that is where we are getting the name tension type. Like the vessels feel tensed up a little. So there are two main subtypes for that. We have the episodic, one of them, and the other one being chronic. For the episodic, from the term episodic, they're usually moderate intensity and they occur in episodes. So they're usually associated with stressful events, for example, exams, etc. So further subdivisions, we have infrequent episodes and the frequent episodes. So the infrequent ones usually occur about like once a month. For the frequent ones, they occur like about 1 to 14 days in a month. So for the chronic type headaches, they occur actually for more than 15 days in a month. So yeah, basically they're chronic. So I think that is self-explanatory. So often they recur daily and are associated with contracted muscles of the neck and scalp, and usually bilateral or occipitofrontal areas of the head. So some etiologies of headache, basically we have dehydration, skipping of meals, depression, stress and anxiety, poor posture, and drinking too much alcohol, sorry. So people having hangovers, and yeah, I think uh, some of you are familiar with that. So for the pathophysiology, it's usually multifactorial. We have an interplay of muscular and psychogenic factors. The environment also plays a role. We have some genetic factors, and also some underlying pain mechanisms, which are usually dependent on an individual. So the basic clinical features for the tension type headaches, usually the patient will have basically they'll describe it as a dull pressure and the head fullness. So the head feels large, or more descriptively like a tight cap or band, like we said before, like they have a tight rubber band stretching on the head. So sometimes they're associated with tenderness in the scalp and neck. The pain should not be elicited over the temporal arteries or positive trigger zones. For some patients with the occipital tension headaches may be very tender on the upper cervical muscles when they're palpated. That is basically the muscles around the neck region. So basically, this is a description of the tension type headaches. So the orange areas are basically uh, regions of pain. And you can see sometimes the neck muscles from this pink region over here. The neck muscles over here are usually affected in some cases. So, okay, there's usually some diagnostic criteria. I'm going to skip this for now. But basically, they'll be based on the duration of the headache and the general clinical features that we mentioned before. So by assessing the duration by which this headache has been occurring in the patient, and also the characteristics, that is, what region is paining? Is the pain dull? Do they feel like they're having a stretched rubber band on their head, etc.? So those are basically the clinical features that will be used in the diagnosis. So management usually. So for the goals, you're trying to relieve the pain and also reduce the occurrence and improve function. Basically, you're trying to prevent the patient from being impaired from doing other things because of the headache. So basic treatments, we have the pharmacological ones, which we said initially. Sometimes you can use a hot or cold pack. Sometimes uh, electrical stimulation, improvement of the posture, trigger point injections, then the occipital nerve blocks can be given. Uh, you can also recommend stretching, regular exercise, balanced meal, acupuncture, massage, etc. So for the pharmacological ones, so we'll just over-the-counter medication depending on the severity of the pain. So, but usually then normal over-the-counter medicines, the NSAID usually work really well. So basically, you can give ibuprofen, naproxen, ketoprofen. For the ibuprofen, you'll usually give about 200 to 400 milligrams four times daily. That is 4 to 6 hours, or whenever necessary. So usually depending on whether it's an adult or a kid. So for kids, you usually give the 200 milligrams, adults, then the 400 milligrams. You can also give aspirin. So in the doses of 325 to 650 milligrams. So yeah, sometimes you can give barbiturates as well, but that is, they're usually given in combination with aspirin and acetaminophen. And also induce sleep. So caffeine is used to increase the GI absorption of this drug. So basically, if you are usually keen and have come across drugs such as Maramoja, you'll find they usually have a combination of aspirin, acetaminophen, that is PCM, and caffeine to some degree. So caffeine usually helps to improve the absorption of this medicine. So the acetaminophen, that is paracetamol, usually you give it, depending on whether it's a child or an adult. For adults, you'll give 1 gram 3 times daily. For kids, it's recommended you give about 500 milligrams, but you should not exceed 4 grams in a day, because it's going to lead to acute liver toxicity. So you can also give antiemetic or sedatives. That is if the patient had nauseating symptoms, then you can add for them an antiemetic drug, such as promethazine, metoclopramide, etc. So for very, very maybe severe cases, which usually recur, you can give the ergot alkaloids. An example being dihydroergotamine, which are usually the 5-HT receptor antagonists. Okay, so for the migraines, okay, so migraines, sometimes people usually say, okay, most people usually say, they usually think of them as headaches, but they're usually more of neurological disorders, not just the normal headache pain. So migraines usually are associated with some other symptoms. So sometimes the headache might be associated with symptoms such as visual symptoms, sensory symptoms. The patient might have symptoms such as nausea, vomiting, etc. So for the sensory symptoms, we usually call this the aura. You might find the patient describing, they usually feel it before they get it's a symptom that usually occurs before the patient actually gets the migraine attack. So they'll either have, they might be smelling something, usually smell just a weird smell they describe as getting that isn't actually there. And it's usually because, like we said before, it's actually a neurological disorder. So the neurons actually get these sensory symptoms, which are basically not really there, but they're usually like warning symptoms before the attack happens. So migraines are usually classified into the following classes. So we have migraines without aura, which are basically called the common migraines. So basically, they won't have those sensory symptoms. We have sometimes probable migraine without aura. We have migraine with aura, which are also referred to as classic migraine. And then we have the probable migraine with aura. We also have chronic migraine associated with analgesic overuse, etc. So basically, I don't think the classifications are as important for now. The most important thing will be the presentation and the etiology. So for the etiology, migraines usually have a very strong genetic association. So familial hemiplegic migraines, they're usually a rare type of migraine which with aura, and they precede, also followed by hemiplegia, which resolves. So basically, this one usually runs within families. So you have migraine in other inherited disorders, such as some mitochondrial disorders. You have migraines and other vascular disease people who suffer from migraine headaches, or who are more likely to have cardiovascular or cerebrovascular disease, such as stroke. So some hormonal changes can precipitate the occurrence of migraines. So especially during the menstrual cycle. We have stress, excessive or insufficient sleep, medication, especially the vasodilators and the oral contraceptives. We also have smoking and exposure to bright and fluorescent lights being triggers. So there are a couple of other things. So strong odors, head or trauma, weather changes, motion sickness. I think you're familiar with some of these symptoms because there are so many people who will tell you that very strong perfumes give them headaches, etc. So they're just common factors. So for the pathophysiology, so migraines are usually thought to be neurovascular. The pain syndrome usually has altered occurs due to altered central neuronal processing. We also have a rare subtype of migraines called the familial type, which you said. This one is actually inherited and is usually due to genetic defects in the in chromosome 1, 2, and chromosome 19. So these are usually the hypothesized sequence of events that occur during migraine attack. So sometimes we'll have the modulating factors. So factors such as drugs, then environmental factors, maybe it's too hot or it's too bright or the hormones, etc. Just the factors that we mentioned. So they cause a disturbance of in the cortical area of the brain and the brainstem excitability. So this results to those sensory symptoms, the aura that we mentioned before. So sometimes we have the brainstem activation, activating the pain receptors. Summary or this is just a summary of how the sequence of events usually occur. So for the signs and symptoms of migraines, so usually the attacks are usually heralded by a prodrome, which is basically a sensation that migraine is beginning. So patients will usually exhibit some mood changes, some loss of appetite, some nausea, or a combination of these symptoms. So an aura precedes an attack, and it usually occurs in about 25% of the patients. Not all patients actually experience this. So auras usually are temporary neurological disturbances, which affect the sensation of balance, muscle coordination, or vision. And they usually last from minutes to an hour thereabout. So the auras in some cases usually persists after the headache has occurred, and that is the migraine, of course. And in some common auras involve the visual symptoms. For example, what you have on these diagrams over here. So the patients will actually have some binocular flashes. Basically, they're seeing things in 2-2. They have arcs of scintillating lights, of bright zigzags, etc. So they usually have view things in ways that have been described over here. So yeah, so these are some of the visual symptoms. They'll see some patchy white stuff in their field of vision. Okay, so sometimes we have paraphasias, which is basically some numbness and like pins and needles sensation. So typically, usually starts in one hand and then marches to the ipsilateral arm of the face, basically one side of the body, like on the same side. So if it's on the left side of the arm, the numbness will also proceed to the left side of the face, etc. So some patients usually have an aura with little or no headache. And the headache usually varies from moderate to severe, and attacks usually last for about 4 hours to several days. And sometimes they usually resolve with sleep. So the pain is usually unilateral, but maybe bilateral. And most often, the frontotemporal distribution, and is typically described as pulsating and throbbing. Yeah. So basically, when we described the other tension headache, we said they'll actually be non-throbbing or non-pulsating. But for the migraine headaches, they'll actually present as in a throbbing manner. The frontotemporal region will actually be affected most. So for the tension headaches, we said basically we'll have the neck region being affected as well, which isn't a feature for the migraine headaches. So, and in most cases, the patient will have it either, will complain of either unilateral or in some cases, bilateral pain. So the symptoms are usually associated with symptoms of nausea, occasionally vomiting. We also have photophobia, sonophobia, and osmophobia. So if you've encountered some of these patients, usually they don't want noise, like they get really irritated by noise. That is basically the sonophobia. And sometimes photophobia, and it actually worsens the symptoms. So sometimes the patient will report difficulty in concentrating during attacks. And the routine physical activity usually aggravates the migraine headache. So this effect plus photophobia and sonophobia usually encourages most patients to lie in a dark and quiet room, basically, which is secluded and away from some of these triggers. So severe attacks can be incapacitating. Basically, they'll disrupt the normal life of this person. So attacks can vary significantly in terms of frequency and the severity. So many patients usually have several types of headache, including the milder ones without nausea, and others will actually get the more severe ones with nausea or without nausea and vomiting as well as with the other neural sensory symptoms that we mentioned. So for chronic migraines, usually the patients will get the headaches for about 15 or more than 15 days in a month, or for more than 3 months. So this is usually very critical for diagnosis. They usually say if the patient has had the frequent headaches for like 15 days or more, it has to be for at least 3 months or more for you to actually get to that conclusion that it's actually a headache, in comparison to the other symptoms that we mentioned of the nausea accompanying the headache. So the headache disorder usually used to be called combination or mixed headache in the past. So these headaches are often developed in patients who overuse drugs for acute treatment of headaches. So there are usually these patients who would take a lot of medications for the headache. So anytime they have a slight headache, they go take on over-the-counter medication or maybe even a stronger medication, the opioids like betapine. So over time, it becomes a triggering factor to these patients. So other symptoms of rare forms of migraine usually include the hemiplegic migraine and what we call the basilar artery migraine, which usually has a combination of vertigo, uh, ataxia, and visual field loss. Yeah. So basically, this describes the sensation of and presentation of migraine in some of the patients. So like we said before, the sensation is usually frontotemporal. So basically on the frontal parts of the head area and also the temporal region. And it's also most commonly ipsilateral, so occurring on one side of the head. So the patients usually also describe certain things like someone is knocking on the head with, this disturbing instruments, as you can see in that particular diagram. So, but not all headaches, migraine headaches will actually present with those symptoms. Some are usually mild, yeah, but the general symptoms are usually quite common in a majority of the patients. So for the diagnosis, usually the patient usually has at least 5 attacks, which fulfill 3 of the following criteria. So first, the headache attacks must have lasted for about 4 to 72 hours. That is untreated or unsuccessfully treated. The second symptom usually, second factor usually, the headache must have had at least 2 of the following characteristics, either unilateral in location, throbbing or pulsating, and also either moderate to severe in intensity and also aggravation by or causing avoidance of routine physical activity. Yeah, I think these are just basically features which you mentioned before. So if the patient presents with a headache that is occurring for 4 or between 4 to 72 hours, and also it's unilateral in location or pulsating, or has any of these 2 symptoms over here, then we actually consider the patient as having a migraine headache. And another factor which is usually considered is usually the sensory symptoms, either nausea, vomiting, the photophobia, sonophobia, etc. So for diagnosis of migraines with aura, the following criteria must be met. So 1 or more visual or sensory speech or motor brainstem or retinal symptoms, as well as 2 of the following in the patient. So either at least 1 aura symptom spreading gradually over 5 or more minutes, or each aura symptom lasting between 5 minutes to 60 minutes, or at least 1 aura symptom being unilateral. So for the management of migraines, usually we have to make a successful diagnosis. Now that your patient has the migraine, then you assess disability. Like to what level or to what degree is your patient being affected by the symptoms? Like, does the symptom of this patient actually prevent them from doing the normal daily activities? Also, you need to educate the patient on their symptoms, the triggers, how to avoid them, etc. And also on individual management, like based on the relieving factors, basically knowing what will help the patient feel better. Then we also have the stratified care approach. So for goals of treatment, basically, basically it's to reduce the pain and basically prevent disability or reduce disability. So for the non-pharmacological treatments, usually you have some cognitive behavioral therapy. For example, you tell the patient to avoid the triggering factors. So if it's very large noises, if it's very strong sense or orders, just tell the patient to try and avoid those triggering factors. Also, there's biofeedback. Basically, this treatment technique usually is for trained persons to improve, you basically train their patients to improve their health using signals from their own bodies, basically just trying to cope with the condition that they have. So you can also recommend relaxation, etc. So for the nerve stimulations, I usually over here, the electrical nerve stimulation, etc. So for the abortive therapy, so you can give a patient NSAIDs, but in most cases, NSAIDs usually are given for the moderate cases, but they're usually not really as effective. So you find most times patients being given drugs such as the ergotamine or ergot alkaloid derivatives, for example, the triptans, the sumatriptan, naratriptan, rizatriptan, etc. Or for extreme cases, patients are usually given opioids. So the opioids usually as things like tramadol, although tramadol is usually not recommended because of the surgery effects, as patients will most likely be given the less stronger opioids, for example, betapine, etc. So for the ergots, basically the most common ergot use is dihydroergotamine. Usually recommend between 0.5 to 1 milligrams given subcutaneously, or 4 milligrams as a nasal spray. So the triptans, these are usually the common ones to give. And they're usually given orally. I think the most common one here is usually the sumatriptan, because I think I've come across the sumatriptan. The mitriptan, I think, okay, I've come across it, but it's not really common in the market. So patients will usually be given like 50 to 100 milligrams per oral for the sumatriptan. So you can also give the patient valproate. And this is usually for patients who cannot tolerate the triptans or other vasoconstrictors. So the use of abortive medication must be limited to 2 to 3 days a week to prevent development of rebound headache phenomenon. So like we said initially, like some patients, usually if they overuse these medications or pain medications, they usually actually end up getting the headaches as well. So when you're giving this abortive therapy, they recommend that you don't give it for more than 2 to 3 days in order to prevent development of this rebound headache. So usually have some drugs which are given for to prevent the migraine headaches. So these are basically different from drugs which are used for as abortive therapy or basically treatment. So for abortive therapy or treatment, basically the treatments and valproate sometimes patients are given opiates depending on the severity or what works for the patients. So sometimes the treatments don't work for certain patients, so they'll end up being given the opiates, which are usually stronger painkillers. So for preventive drugs, basically, these are just drugs which are given as prophylaxis. And you'll find a lot of the hypertensive drugs being used over here. And usually we recommend the beta blockers. So these ones also help with, as you know, anxiety and also coronary artery disease. And like we mentioned before, they're usually like triggering factors, the anxiety, and also some cerebrovascular or coronary artery disease. I think we mentioned it before. So, but other patients usually can be given this just for prophylaxis and not really management. So other than the beta blockers, you can also give the TCS. Basically, the mainstay is usually the amitriptyline, usually 10 to 100 milligrams per oral. And it's recommended at bedtime. So the patient can also be given topiramate. And yeah, sometimes they can be given verapamil. Although verapamil, okay, it's a calcium channel blocker, but the efficacy is usually very low. So for the second line, prophylaxis, if the first line wasn't as effective, you could give methotrexate, sometimes flunarizine, flunarizine, or the monoamine oxidase inhibitors. So sometimes the cyproheptadine and gabapentin can be given, although these ones have unproven efficacy for in the patients. So basically, this is an algorithm for the management. So in summary, we'll just say, so usually start with the non-pharmacological treatments, and you'll basically give the patient some education regarding the conditions, avoiding the triggers, etc. So if this patient will have moderate symptoms, mild to moderate, usually just give mild analgesics. So they usually recommend they're usually more effective as compared to things, other NSAIDs such as aspirin. But you give them in combination with an antiemetic such as promethazine, metoclopramide, sometimes ondansetron can be added. So you can give a combination of analgesics and caffeine. If the patient has symptoms such as the vomiting and etc., the nausea, basically you just add the antiemetics for that purpose. So for the severe symptoms, patients usually given the hydroergotamine nasal spray. If they don't work for the patient, you give the patient the opioid analgesics. If still they don't work, then you recommend corticosteroids, and sometimes valproate can be used for severe cases. So I think the last type of headaches that we look at, it's basically the cluster headaches. So cluster headaches are usually also known as histamine headaches, and they're usually a primary neurovascular type of headache disorder. So cluster headaches usually cause an excruciating unilateral periorbital or temporal pain with ipsilateral or autonomic symptoms such as psychosis, lacrimation, rhinorrhea, etc. So basically, if you were to compare the symptoms of cluster headaches and migraine headaches, they're almost similar because they're also unilateral. But the main distinguishing factor here is usually that for the cluster headaches, they're usually periorbital. Basically, they affect the region around the orbit, basically where we usually have the eye cavity. So they're usually rare and are called cluster headaches because they happen in clusters. That is for a month or two at a time, or around the same time in a year. So they usually affect primarily men, and they usually begin between the ages of 40 years. So for the diagnosis, basically, we'll have to look at the clusters, like the headaches occurring in certain times of the year or certain periods or seasons. So the patient usually experiences attacks of severe or very severe, and it's usually unilateral, uh, and it's usually orbital or supraorbital, and sometimes it can be temporal. So the attacks usually associated with one or more of the following. That is, they'll occur ipsilaterally. Then we'll have the conjunctival redness, lacrimation, nasal congestion, rhinorrhea, etc. So for the management, usually the goal of treatment is usually to prevent severe attacks, and that is usually give abortive agents for that. Then for prophylactic agents, usually try to reduce, you're just basically trying to reduce the frequency of occurrence of these headaches. So the treatment will basically be almost similar to what we mentioned in migraine headaches. So for the non-pharmacological treatment, sometimes they give nerve block agents. Sometimes brain stimulation can be used. Sometimes ablative procedures and radiotherapy can be used. But those are for extreme cases. So for abortive attacks, the drugs that we use, basically like we said in the migraine attacks, we'll give the triptans or the ergot alkaloids, for example, the dihydroergotamine. Then you can also supplement that with oxygen and anesthetics. So for long-term prophylaxis, verapamil is usually recommended. You can also give lithium, topiramate, and divalproex as a combination. So acute attacks, these are usually recommended that you give, again, triptans or dihydroergotamine. Then you add sometimes oxygen to the patient if it's very severe and the patient is also highly disabled. So for secondary headaches, these are basically headaches that occur due to an underlying condition, like we said before. So the other types of headaches, the cluster, the migraine headaches, and the cluster, the migraine, and the tension headaches, they're usually the primary headaches. So they don't really have any underlying mechanism. But for secondary headaches, they usually occur due to some underlying mechanism. So for these ones, usually they recommend you treat the underlying mechanism in order to prevent the headache from the patient. So they're usually related to physical problems, and management is basically by treating the underlying or the organic cause. So we have certain examples. We have these ones which occur as due to space occupying intracranial lesions. Basically having, these are just headaches which are associated with intracranial tumors. So we have classic tumors, classic headaches of this type usually wake a person from sleep at night and are associated with projectile vomiting, etc. So this is very common in patients with, tumors, brain tumors, etc. I think this is quite self-explanatory. So there are those ones which occur due to trauma. So after a person maybe had a trauma to the head, then they got concussed. After some time, months to years later, you find that they have these headaches actually recurring. So we also have headaches occurring due to meningeal irritation. So basically irritation of the meninges. So basically this occurs in situations such as, what do you call this? The meningitis. We'll have patients usually experiencing a very severe headaches. So that can be an underlying cause that the meninges were inflamed, and as a result, they trigger the headaches. Sometimes you have the post lumbar puncture or the spinal headaches. So sometimes when a patient has meningitis, you might need to do a spinal tap for this patient, basically to assess the CSF. So usually when the CSF is removed, it triggers the headaches to this patient. I think due to the reduced volume of the CSF that has been removed from the patient. So that's why usually they recommend to only remove about 10 to 20 ml, I think, 10 to 20 ml of fluid from the CNS during the spinal tap. Because if you take more than that, patients end up getting a lot of these headaches. So basically, they're usually self-limiting, but you can also advise the patient to take a lot of fluids, sometimes caffeine. Yeah, basically try to replenish that. So you have these pains which are referred to as referred pain. So referred pain is usually basically an injury occurring somewhere in the body. Then due to severe pain in that particular region, they cause a person to have a headache. So for example, sometimes patients with toothaches, they usually complain with, they have headaches as well. So usually it's just that the patient is experiencing a lot of pain from a different region, and this triggers the headache to occur. So, so headaches usually of this form may occur due to pain from neighboring structures of the head. So one of the symptoms is usually the temporomandibular joint disorders. So basically, just stuff to do with the jaws being injured, etc. So for this, the symptoms usually last for a few months to years before they actually get better. Some example, like I said, we have the dental disease. We also have the upper neck disease. Yeah. Sometimes they spill over, causing the patient to have a headache. We can also have the idiopathic ones. This basically don't really have known cause, but it usually occurs due to a disorder usually occurs most commonly in women, and thought to be due to increased intracranial pressure. Basically, recommend drugs to reduce the intracranial pressure. Basically, the osmotic diuretics, yeah. And acetazolamide, I think, is usually more recommended. So for painkiller headache, so like we said before, sometimes we have patients who overuse. So we have, yeah, patients who overuse some painkillers, then they end up getting headaches as like a rebound mechanism to the overuse of these painkiller medications. And yeah, lastly, maybe you can look at the carbon monoxide poisoning. So this is quite common because when a person or the patient has been exposed to carbon monoxide, basically due to inadequate oxygen flowing to the brain, they becomes a trigger to the development of these types of headaches. So I'll share the notes with you guys, then I think you can have a look at them. So if you don't mind, maybe you can take a brief break, about 5 minutes, then I'll share some other notes. Then we'll look at some other disorders. So mostly the other disorders see difficult things. Some of them like epilepsy and seizures, neurological disorders. I think we mentioned them yesterday. So it's a to just rushing through them. So just 5 minutes break. I'll share the other notes. Alafu we'll continue with that.
Yeah, before Sam starts, we're going to ask for active engagement. The topic displayed is schizophrenia. I'm sure everyone knows something about schizophrenia. You guys did what rounds in Madare for like a year. Yeah, so kindly unmute, say something about schizophrenia. What do you know about schizophrenia? Its treatment, its symptoms, anything you know about schizophrenia, so that we don't have to go into every single detail. We can just cover it in a few minutes and go to the next disorder and the next disorder. Remember, we only have today, actually, we only have the 1 more hour to finish neurology. Schizophrenia. Unmute, say something you know about schizophrenia.
Okay, so schizophrenia, it's when the dopamine levels there's overactivity of dopamine, which causes positive symptoms. But then in the prefrontal cortex, there is increased serotonin, which leads to decreased dopamine. But now that's in the prefrontal cortex. So that causes the negative and the cognitive symptoms. So I think the dopamine is high in the mesocortical region, causing positive symptoms. And serotonin is high in the prefrontal cortex, causing negative and cognitive symptoms. I think that's like the overview of like the pathophysiology. And I think there's also deficiency of glutamate or glutaminergic neuron, something like that. Not too sure about that.
Nice. So Hiral has told us the pathophysiology, that schizophrenia is all about majorly, let me say majorly, it's about dopamine dysregulation. And here we are having the hyperdopaminergic activity in the mesolimbic area, giving rise to those positive symptoms, and hypoactivity in the mesocortical pathway, giving the rise to the negative symptoms. So those are the mesolimbic. We have hyper. In mesocortical, we have hypo. Yeah, and then also there's been a hypothesis that also the glutamate is involved in the pathophysiology of schizophrenia through some malfunctioning of the NMDA receptors, which will impact the dopaminergic activity in both the mesolimbic and the mesocortical areas. Also, she's talked about that serotonin has also been implicated in the pathophysiology of schizophrenia. Hence, we know even the second generation antipsychotics, they have some serotonin modulation activity. So someone else pathophysiology has been covered. Someone else symptoms. We are talking about positive symptoms.
So the symptoms of what's it called, schizophrenia, Hiral has talked about when the dopamine is excess, you have positive symptoms. So by positive symptoms, it means these are symptoms that are they're added to the person's personality that you didn't have them before. So for the most part, it will be delusions, people might think like there are people coming for them and there's something attacking them. So there's delusions, there's hallucinations, both visual and auditory, seeing things that are not there or hearing things that are not there. What else? Yeah, those are the most prominent positive symptoms. And then there's the negative ones. So the negative ones are to do mostly with the serotonin. So a person with schizophrenia might go through periods where their moods are really low. They become catatonic. They might not want to move. They might not want to do a lot of things. They might not eat. They might not be able to get out of bed. So yeah, those are the common manifestations of schizophrenia.
Great. Yeah, the positive symptoms, the negative symptoms, yeah, the hallucinations, delusions, nice. And the negative, especially on the mood, the lack of social drive, such things. Yeah. So those are the clinical presentation. Corazon is also talking about polymorphism of the COMT gene reduces dopamine release from the prefrontal cortex as well. Polymorphism of the COMT synthesis of that COMT enzyme, which we know is involved in the breakdown of dopamine. So when there is that polymorphism, it will lead to a reduced release from the prefrontal cortex. Yeah. So we've looked at pathophysiology, we've looked at the clinical presentation. Something else, what do you know about schizophrenia? People here went to ward rounds in Mathare. Brenda?
The diagnostic criteria for schizophrenia, we use the DSM-5 criteria, where we can assess the symptoms for a period of 1 month if they have either the positive symptoms or the negative symptoms that have been mentioned, such as the delusions, hallucinations. Yeah.
Yeah, nice. So diagnosis, we use the
Can we also talk? Can we also say that from what I learned in Mathare, so there's some people who if you're predisposed to schizophrenia, sometimes like taking drugs like marijuana, smoking it extensively, usually might cause something to become schizophrenic.
Yeah, so there we've gone out to the risk factors. Yeah. Abuse of drugs such as marijuana. Any other risk factor?
Genetics.
Genetics, true. That genetic components.
Also, there was age.
Yeah, age usually between your teenage years to your 30s. That's when you're more likely. That is when the symptoms appear. So the young, between 15 to 30 there, right?
Genetic and family history need the same.
Okay, not always genetics and family. It's not always the same, because family history is someone in your family has had it. Genetics means it's an alteration in the genes that's somehow, yeah. So it's not always the same point, genetics and family history.
Okay.
So look at the risk factors. I think even by mentioning the age, that has covered the epidemiology, that it will mostly affect people in the late adolescence to their early adulthood period. Look at the positive and the negative symptoms, right? The dopaminergic dysfunction, hyper in the mesolimbic, hypo in the mesocortical, the criteria for diagnosis, right? Someone must have had those symptoms for at least a month. You know, the positive symptoms, the delusions, the hallucinations, the negative symptoms, the loss of the mood is disturbed, the disorganized speech, such things. Now, lastly, we are going to management. Management, let's start with pharmacologic. This is the major one. The non-pharmacologic, we know it's all about cognitive behavioral therapy. So pharmacologic, yeah. Watu wajaongea.
Antipsychotics. So first generation and second generation. So the second generations are the ones that are mostly used because they're the ones in terms of metabolism, they're more stable. So the second generation, let me start. The first generation, there's flufenazine. There's something we started on H, I've forgotten them. And then the second generation, haloperidol, yeah. And then the first generation, I think they stopped using them because the side effects were really strong. And I know the side effects are the extrapyramidal symptoms. So there was there was one where you were shaking, and then there's the one where the person, what's it called? That's where they were removing saliva from their mouth. I don't know what it's called scientifically, but it was one of the extrapyramidal symptoms. I know there are 4 extrapyramidal symptoms. And then the second generation, there was now risperidone, olanzapine. Someone else can add, but I can say about the second generation, there was one like olanzapine, I think, was the one which was causing rapid weight gain, which might affect the mood of the person who is schizophrenic to start with. Yeah.
Nice. So she's talking about the first generation, talked about their major disadvantage being having those extrapyramidal side effects. Jambi is also mentioning that the first generation will worsen the negative symptoms. Yeah. So the extrapyramidal side effects, Sarah was saying there are 4 of them. What are the 4 extrapyramidal side effects? They have
tardive dyskinesia, and then there's akathisia, and then there's dystonia. I think dystonia is the one that has the muscle spasm. And then the one that has the rigidity, the tremors, I don't know, it's the one that has effect to Parkinsonism symptoms. I think it's called something. I don't know the real name, but it's the one that has the tremors, the rigidities. I think that one is due to Parkinsonism. It's because there is dopamine. It will lead to dopamine antagonism in the nigrostriatal pathway, negative feedback distribution of it. Yeah.
Okay, great. So you can see Diana has given a nice mnemonic there, TRAPS. Maybe Diana, you can tell us what TRAP and S stand for in TRAPS. And meanwhile, for acute dystonia, Jambi is mentioning we give Atane or Benzhexol. For tardive dyskinesia, we give the benzos. For akathisia, which is the inner restlessness, you know, they have to do something with their muscles. We give a beta blocker. Yeah. Then examples of the first generation antipsychotics, they were mentioned, the likes of haloperidol, flufenazine, chlorpromazine, and such things. Second generation, olanzapine, risperidone, right? Now, what's the issue with the second generation antipsychotics? Can even mention just the common, olanzapine and risperidone. We don't have to go so deep into the other ones. Olanzapine and risperidone.
Definitely the weight gain.
The weight gain. Yeah, nice. The weight gain.
Clozapine, they're also associated with weight gain.
So yeah, clozapine also associated with weight gain, but clozapine, we were saying it's usually the last line antipsychotic. Why is this so? What makes clozapine? Why do we save clozapine that much? Is it the side effects, or is it that it's very, very, very potent? What's unique about clozapine?
Was it the side effects? Like, was it the one which caused them to be suicidal, Amma? No.
I don't know.
Okay, I don't know, Basi. I don't know, but I remember I was saving clozapine for last because maybe it also has heavy side effects.
So yeah, she said it's the side effects. And so which side effect? There's one particular side effect that really limits the use of clozapine.
I'm not sure, but I think agranulocytosis.
Yeah, granulocytosis. You have to keep monitoring these patients' CBC, right? The neutrophils. They can easily get infections. So it really makes, giving a patient clozapine, it's a lot of work for you. You have to keep monitoring, yeah. Then now the mechanism of action. I think we've mentioned the side effects. We haven't mentioned the mechanism of action. What's the general mechanism of action for first generation antipsychotics? The general. Mechanism of action of antipsychotics. First generation antipsychotics. How do they work?
Blocking the dopamine receptors.
Yeah. D2 blockers. Yeah. Let me pick this call. Yes. You guys continue dropping content.
Guys, what were you asking?
Mechanism of action of second gen antipsychotics.
What?
Mechanisms of action, yeah, first gen and second generation antipsychotics.
First one, the D2 antagonists.
And the second one.
Second one.
Serotonin antagonist.
Yeah, nice. So the first generation, they are predominantly D2 blockers. But the second generation, they have activity in inhibiting both the D2 blockers and they have some antagonistic action on the serotonin, 5-HT. I think is it 5-HT2? Yeah.
Yeah, it's 5-HT2.
Yeah. 5H2 receptors, yeah. Then, anything else someone wants to add on antipsychotics? Dr. Sam has told me to finish for him, so unlucky for you all, you have me, and I don't have slides.
For risperidone, the unique thing about it, it elevates the prolactin levels.
It elevates the prolactin levels. How? Just perhaps you can just explain.
I'm not sure the mechanism of action of the elevation, but I just know it elevates the prolactin levels.
I think when you block the dopamine, is it that the prolactin levels will go up? Like they are usually concurrent levels, if I'm not wrong.
Nice. Remember the other name for dopamine. Dopamine is also known as prolactin inhibiting hormone. So if you block dopamine, it means prolactin is not inhibited. So we give prolactin free reign. So yeah, so we'll see risperidone functioning to, like, it can really elevate the prolactin levels.
Also, aripiprazole was a partial agonist, which means that it was acting as an antagonist and also an agonist at the same time.
Nice. Yeah, aripiprazole was a partial agonist at the 5-HT1 and an antagonist at 5-HT2, right? Yeah, nice. And if you can remember, aripiprazole is one of the antipsychotics which with the safest safety profile. The safest, the side effects are very minimal, and antipsychotic of the rich, right? Because it is very safe, second generation. The side effects are really not major. The effects on the lipids, on the glucose are negligible, making aripiprazole a very good antipsychotic. But now expenses matter.
Guys, for the dopamine and prolactin, here it says dopamine blocks the release of prolactin, whereas the 5-HT2 antagonists, they cause the release of prolactin. Antagonistic property of antipsychotic will cancel the dopamine and 5-HT2 action on prolactin release.
Nice. So yeah, that's another mechanism.
And then here, I'd like to talk about this in Dr. Ermia's notes. It says in mesolimbic pathway, the D2 receptor blocked of antipsychotics are more robust than 5-HT2A antagonism. That's why the second generation antipsychotics, they reduce the positive symptoms. And in mesocortical pathway, the dopamine deficiency will cause negative and cognitive symptoms of schizophrenia. So in mesocortical pathway, the 5-HT2 antagonist receptors, there are more receptors than the dopamine receptors. That's why the 5-HT2 antagonism will have more property in mesocortical than in mesolimbic to reduce the negative symptoms of schizophrenia. And then in neurostential pathway, the 5-HT2 antagonist will bind to 5-HT receptor, and it will block the release of serotonin and thus cause more dopamine to be released. This is where the extrapyramidal side effect of first generation is reduced by second generation, because the second generation, it acts on serotonin. So when they block the serotonin, they'll cause more dopamine to be released. Hence, the extrapyramidal side effect of dopamine will be reduced. And then the other one that I was talking about is the tuberoinfundibular pathway. That's when the dopamine is released. It's also released prolactin. So, and then 5-HT2A antagonist will block the release of prolactin. So the antagonistic effect of antipsychotic will cancel the dopamine and 5-HT2 agonist action on the prolactin release.
Yeah. Great. So she's explained that the pharmacology of the different dopaminergic pathways and why first generation are better for positive symptoms, second generation are better for the negative symptoms. Okay. Jambi has added that the high prolactin levels can cause amenorrhea, they can cause gynecomastia, they can cause galactorrhea, and can also cause infertility. Remember, prolactin, the release of prolactin is stimulated by the gonadotropin releasing hormone. So if we are having high prolactin levels, it goes and tells the hypothalamus, yo, don't release the gonadotropin releasing hormone. If no gonadotropin releasing hormone is produced, that means we're also not producing FSH, we are not producing LH. So if we are not producing FSH and LH, of course, we expect this amenorrhea, we expect this galactorrhea, the infertility will definitely be there, right? Then for gynecomastia, I think that is obvious, prolactin's effect on the breast tissue. Remember what we said, both men and women have breast tissue. It's only that in one gender, they have a lot of breast tissue as compared to the other gender. Mystique has also added that clozapine is given to patients who are at risk or are having suicidal thoughts. Alimia is adding that clozapine is usually given for treatment of refractory schizophrenia. Stanley from Goomba is also saying that the 4 dopaminergic pathways are the nigrostriatal pathway, the mesolimbic pathway, the mesocortical pathway, and last but not least, the tuberoinfundibular pathway. Yeah. So those are the 4 dopaminergic, the 4 major, let me say the 4 major dopaminergic pathways. Unless someone has something to add on schizophrenia, anyone? If nothing to add, we'll move quickly to the related disease of schizophrenia, that is bipolar disorder, BPD. So BPD, what is BPD? Bipolar disorder. What do you know about BPD? You know, everyone is always saying, oh, you know, I'm bipolar. What does bipolar mean?
It's when you experience extreme emotions. So like normally, you're supposed, like, people are happy and people are sad. People with bipolar, they experience the extreme ends of either emotions. So they can go from really happy, delusionally happy, to extremely sad, and usually it happens rapidly. Although for some people there's an established cycle. Usually the really low mood comes after a really high mood, and I know when you're in like really high spirits, there's grandiose delusions where you might think you're a bigger person than you are, and then it might lead you to overspending your money because you think you have more money, and you do a lot of activities that give you like the dopamine rush. And then extremely low moods, they are accompanied by suicidal thoughts, being really sad, not moving around a lot, not participating in day-to-day life and all that.
And nice. Yeah, so she's giving us an introduction of bipolar disorder. It's characterized by those 2 extremities, you know. You can be really happy, right? We call it mania or hypomania. Then you can also be really sad. It's the depressive episode. Yeah, so that is why bipolar, there's a high and there's a low. And they say, let me not say what they say, but otherwise it's a really sad disease because most patients will spend a longer time in the lows than in the high. That's the sad part. Someone else with something on bipolar disorder?
There was also 2 categories of bipolar 1 and 2. So for bipolar 1, it was mostly affecting both men and women, and it has more than one manic phase. And bipolar 2, it's mostly in women and mostly has depressive states.
Nice. So the 2 types of bipolar 1 and bipolar 2. She's talked about the epidemiology between bipolar 1 and bipolar 2. Bipolar 1 is more of manic, and bipolar 2, we are saying it's more depressive and a hypomanic episode, right? Something else, we are not going through these notes. The information is coming
for pathophysiology. For pathophysiology of bipolar, there is elevation of norepinephrine and dopamine, which causes the maniac episodes. And when there's reduced dopamine and norepinephrine, it will cause the depressive phase of the disease.
Yeah, nice. That dopamine being elevated, mania, right? And when it's been reduced, depression. Nice. You can see on the chat box, Corazon is saying that for bipolar 1, the diagnosis is presence of 4 out of 7 symptoms for at least 1 week. Yeah. Remember, with these psychiatric disorders, there is a certain period that has to be attained before it can be diagnosed, right? Or it can be definitively diagnosed. So for bipolar 1, 4 out of 7 symptoms for at least 1 week. Something else on bipolar. Talk about the pathophysiology, clinical presentation.
Etiology, yeah, saying that genetics play a role like majorly, but others include like trauma, environmental factors, anatomical abnormalities. But genetics then that plays a major role as an etiology.
Nice, yeah. So genetics is a major factor or major etiological in bipolar disorder, but the other factors can be the environmental factor, exposure to some drugs, such things. Jam is also adding that for bipolar 2, we just need the presence of 3 out of 7 symptoms for at least 4 days, and the patient has no psychotic features. Right? So I hope we are remembering this, especially the period. The period matters. Schizophrenia, Brenda told us, according to the DSM-5, we need the symptoms to have been there for 1 month. But we are seeing here for bipolar, just for bipolar 1, we are seeing for at least 1 week. For bipolar 2, we are seeing 7 days, right? The presence of these symptoms, right? If we are, then let's go to management then, if we feel we've adequately covered all the other aspects. Again, non-pharmacological, there's always that CBT, such things. We do not cover that. Let's go to pharmacological. How do we manage bipolar disorder? What drugs do we give? The chat box, I'm saying Scooby-Doo, saying that the treatment, first line, we have the mood stabilizers. This fake Spider-Man is asking for notes, and yeah, we are currently fighting quacks, so I won't send the notes. Yeah, so the mood stabilizing agents, right? Anything else in the management of bipolar disorder?
For non-pharmacological therapy, actually, group psychotherapy is one of the first line treatment for non-pharmacologically. Group therapies, like something like cognitive behavioral therapy, where the patient is taught like self-management, the skills to change the negative thoughts the patient has. And then there's electroconvulsive therapy. It's an electrical impulse to the brain for treatment of severe depressions and mixed states of psychotic and refractory maniac bipolar symptoms. It's this electroconvulsive therapy. It's also used in pregnancy women who cannot take some bipolar medications like lithium, mood stabilizers like lithium. It's contraindicated in pregnant women, but this convulsive therapy, it's very effective for them. And just to stay away from drugs like alcohol, to exercise. Yeah, basically it's more of like taking care of the sleep. Even the sleep helps a lot. You should have a good night's sleep. Yeah, that's basically non-pharmacologic therapy.
Nice. So she's got the non-pharmacologic. Jamie is adding that for bipolar 1 is the manic bipolar. You should not give SSRIs alone since they can reverse the depression back into the manic phase, right? That's give together. So if you have to give an SSRI, you have to give together with the mood stabilizers. We're talking about mood stabilizers in general. Now let's go to the specifics. They've even been listed there. We have lithium, we have valproic acid, carbamazepine, and lamotrigine. What's the mechanism of action of these drugs? What do they do? All these things. Let's now stop talking about mood stabilizers as a whole and tackle the specific drugs. Carbamazepine, valproate, lamotrigine. What do you know about any of the drugs listed there? Lithium. You can unmute my keyboard warriors. You can also type on your the chat box. Mood stabilizers. We have even people who went to attachment to Madare. They're the ones who should be leading these psychiatric disorders. Not Jambi, were you in Madare? I'm not sure. But Tevin was in Madare and he's here. Brenda, you are in Madare. In attachment. Nightwing was in Madare. Food stabilizers, the lithium, the valproate, the carbamazepine. What did you note about them? What is the mechanism of action? Which ones were even common in which ones were the patients being given more commonly? Is it the Tegretol? Is it the Valters?
It was carbamazepine.
Carbamazepine, nice. Carbamazepine.
Yeah.
So well, pharmacology of carbamazepine.
Tevin, please, I encourage you to speak.
Spider-Man, fake, he's not sure, but it's talking about they work by blocking the sodium and the calcium channels. Corazon is maybe just clarifying that carbamazepine is an anti-epileptic agent and usually works by blockade of the sodium channels. Carbamazepine is an channels. So in short, carbamazepine is a sodium channel blocker. It's also used for patients who don't respond well to lithium. Going to the side effects. What are the side effects of carbamazepine? What's something that someone should never forget about carbamazepine?
It can cause a
Carbamazepine,
syndrome of inappropriate EDH, or rather it mimics that. Also, it causes hyponatremia.
Nice, because it's hyponatremia. What was the first one? I think I didn't hear clearly.
An antidiuretic effect, which is similar to the syndrome of inappropriate ADH, which will eventually lead to hyponatremia.
Nice. Yeah, carbamazepine has that antidiuretic effect similar to that syndrome of inappropriate ADH secretion, hence can lead to that hyponatremia. Nice. So yeah, it mimics the syndrome of inappropriate ADH and can cause hyponatremia. On the chat box, I'm saying that it's not to be given with clozapine due to agranulocytosis. Someone is also talking about it's a potent CYP inducer and will cause the metabolism of many drugs. So it's a potent CYP inducer. So yeah, you need to know that if you are co-administering it with other drugs. The fake Spider-Man is talking about that you should avoid taking grapefruit juice with carbamazepine since it will increase the levels of the drug in the body. Also, as an addition, talking about the other CYP inducers, the potent ones, we have rifampicin, which is the same as rifampin, carbamazepine, we have phenytoin. I think yesterday we also saw griseofulvin as a CYP inducer. Yeah, Black Panther is talking about this drug is known to cause Steven Johnson syndrome. So you should watch out for that. Yeah, if patient starts complaining a rash is developing and such things. Yeah. As an addition, Abdul Malik is saying that they also use for the treatment of trigeminal neuralgias and the other related neuralgias. Also that the drug is teratogenic and as such should be avoided in pregnancy. Yeah, have we exhausted the side effects of carbamazepine? We go to the next drug. Right. So lithium. What about lithium? No, it's not commonly used, but what lithium? How does it work? What are the side effects we expect from administration of lithium to a patient? kindly let's answer because so that we can cover one last disorder before we close on the neurologic disorders.
Okay. From what you were told in class, is that the mechanism of action is unclear. However, it's thought to interfere or inhibit phospholipid turnover. And then now that reduces the activity of second messengers. Then the net effect is to affect nerve conduction and calcium metabolism.
Nice. So mechanism of unclear, but thought to have for lipid metabolism. Kindly just repeat. I don't wanna
Interfere or inhibit phospholipid turnover, thus decreasing, thus decreasing the activity of second messengers. And then the net effect is to affect nerve conduction and calcium metabolism.
Yeah. So the net effect is that affecting the nerve conduction, yeah, and that is through the inhibition of those second messenger systems, right? Cyclase, it has inhibitory effect on inositol. So we have this nerve conduction being disturbed. But given that the mechanism of action is not really known, let us go to the side effects, which are better known. So what side effects do we expect with lithium? If given a patient lithium, what side effects are we expecting? Hey, my chat box people are saying hypothyroidism, hypo, that is low, hypothyroidism. Also abdominal discomfort. We have hypothyroidism, abdominal discomfort, tremors, polyuria, GI upset, yeah. A metallic taste in the mouth. Yeah, tremors, metallic taste in the mouth. Abdul Malik is also telling us this drug, lithium, is also another teratogenic drug. Mechanism of hypothyroidism is that lithium will be concentrated in the thyroid gland, and as such will impair the synthesis of the thyroid hormones. So if the hypothyroidism occurs, we ought to discontinue the lithium and give supplementary thyroid hormones, right? Is it L4 or L3? Levothyroxine. Is levothyroxine L4 or L3? I'm not sure.
Hebu rudia kenye umesema kuhusu lithium and lithium induced nini?
Lithium, it's on the chat box. Lithium will concentrate in the thyroid gland, impairing the synthesis of the thyroid hormone. So if hypothyroidism occurs, we should discontinue lithium and give levothyroxine to manage the hypothyroidism.
Because some sources
but
say
just I can see
that this is I mean in inaweza ikiongezeka, it's not an indication to discontinue lithium. Hypothyroidism. Rather kuna supplement.
Okay. Yeah, so some sources state that lithium-induced hypothyroidism is not usually an indication to discontinue the drug. It's not usually an indication to discontinue the drugs. The patients can be supplemented with levothyroxine and continue the drug. So some sources say that lithium-induced to discontinue the drug, that you can continue with thyroxine supplementation, levothyroxine supplementation. Also on the chat box is that long-term use of lithium can lead to structural kidney changes like glomerular sclerosis. Yes, so renal function should be monitored. That Abdul Malik is saying that the high doses can also cause seizures, clonic movements of the limbs, circulatory collapse, and coma. Yeah, the other thing is that lithium has a low therapeutic index. Corazon telling us that the co-administration of lithium with NSAIDs, ACE inhibitors, thiazide diuretics, and ARBs should be avoided. It should be avoided as they can increase the incidence of ADRs by increasing the serum level of lithium. So avoid with ACE inhibitors, ARBs, NSAIDs, and thiazide diuretics. Avoid. Corazon is asking, why not discontinue if and there's better, safer options that won't affect thyroid hormone levels? So according to the text that I'm reading, if this is in the case that the patient's bipolar disorder is only responding to lithium adequately, the other ones, they have not responded adequately. So in that case, you should not discontinue, just continue, but supplement the thyroid hormones. But if the other drugs haven't been tried, you can stop the lithium, try another drug. Yeah, instead of having a polypharmacy situation. If lithium, if we feel what we've covered is adequate about lithium. Finally, let us go to valproic acid or valproics, how you wanna call it. So valproic acid. What's its mechanism of actions? What are the side effects? Valproic acid. Mechanism of action and side effects. Yeah, Corazon is saying that essentially they inactivate the sodium channels and they also increase the GABA concentration. Inactivation of the sodium channels and they increase GABA concentration. Side effects include loss of appetite, dyspepsia, nausea, tremor, alopecia, that it can lithium or an SSRI. Tremor and drowsiness are also side effects, of course, with most anti-seizure medications will have drowsiness as a side effect. Samir emphasizing that valproic acid is used for the treatment of that manic phase. Hepatotoxicity and pancreatitis can occur, however, not that common. On lamotrigine, I think lamotrigine is the other one we have not looked at. Lamotrigine, how does it work? Abdul Malik has added that valproic acid can also cause thrombocytopenia. The mechanism of action is displayed there. Blockage of the ion channels and effect on glutamate transmission. Side effects, majorly we have the maculopapular rash, dizziness, drowsiness, headache, blood vision, and nausea. Drug-drug interactions. Carbamazepine will increase the rate of lamotrigine metabolism, right? Then we have this drug here that is an analog of carbamazepine. Oxcarbazepine. Jambi has also mentioned that for valproic acid, it's essential that you do liver function tests. The drug, as mentioned earlier, it causes that hepatotoxicity. Then comparison between oxcarbazepine and carbamazepine. If you had both drugs, which one would you give and why?
Oxcarbazepine.
Why?
Because it's less likely to alter the hemodynamic. So you don't need the routine monitoring. Also less likelihood of TBI.
Yeah, nice. DDIs are less likely. But what's the one disadvantage of oxcarbazepine as compared to carbamazepine?
Hyponatremia.
Yeah, hyponatremia. Remember that what Brenda talked about, syndrome of inappropriate ADH secretion, right? I think even in diabetes insipidus, who are using carbamazepine as can be used as a treatment. Yeah. I believe that's it. Antipsychotics can also be used. Antidepressants. I think we'll read antidepressants when we're looking at major depressive disorder. As the time is gone, and tupatane 5. If someone is willing to take over, they can take over and do the rest.
I think tunaweza patana 5.
Sawa.
So we stop and we meet at 5, right?
Yes, sir.
Let me stop the recording.